All right, let's dive into a topic that is absolutely critical for anyone in the ICU and a huge favorite on exams like the CCRN, the relationship between mechanical ventilator and the heart. You know that moment you've just intubated a patient and suddenly their blood pressure just tanks? Well, if you've ever wondered exactly why that happens, you are in the right place. We're going to break it all down.
So here's our game plan. We'll start with that clinical puzzle, then I'll give you the one single concept, the master key that unlocks the whole thing. We'll look at what happens with positive pressure, then flip it and look at negative pressure. After that, we'll hit the high-yield concepts you absolutely have to know for your boards. And we'll wrap it all up with a quick quiz to make sure this stuff sticks.
Okay, first up, let's set the stage with a scene that I guarantee every single one of us has seen 100 times at the bedside. It's a real clinical mystery. Here it is, the big question. You did everything right, the tube is in, you hook them up to the vent, and then you look up at the monitor and the blood pressure is heading south. What is actually going on physiologically? Stick with me because by the end of this, the answer is going to feel incredibly obvious. Now, to solve this puzzle, you don't need to memorize a bunch of disconnected facts. Nope. You just need one concept, one master key that explains everything else. And that key is intrathoracic pressure. So what is this thing? Intrathoracic pressure, or ITP, is literally just the pressure inside your chest. It's super simple. When a ventilator pushes a breath in, that pressure goes up. It becomes positive. When you or I take a normal breath on our own, we create a vacuum to pull air in. So that pressure goes down. It becomes negative. This one simple difference is the foundation for everything we're about to talk about. Okay, let's start with the ventilator. What happens when that machine forces air into the lungs and cranks up the pressure inside the chest? I want you to think of this as the squeeze. Now, check this out, because this is where it all begins. As the ventilator pushes that breath in, that positive pressure squeezes two really important things. First, it squishes the big veins, the superior and inferior vena cava. That means less blood can get back to the heart. Boom, your right ventricular preload just dropped. At the same time, it's squeezing all those tiny little papillaries in the lungs, making it harder for the right ventricle to push blood through. So your RV afterload goes up. It's a total double whammy for the right heart, right? Less blood coming in, and it's tougher to pump out. But here's the twist, and this is the part that shows up on every single exam. That same squeeze actually helps the left ventricle. How is that possible? Well, think about it. The left ventricle has to pump against the pressure difference between inside the heart and outside in the chest. By increasing that outside pressure with the ventilator, we're essentially giving the LV a helping hand. We're reducing the amount of work it has to do. So positive pressure decreases left ventricular afterload. This is a huge deal. It's exactly why CPAP can be a lifesaver for someone in cardiogenic pulmonary edema. All right, got all that? Good, because now we're going to flip the script completely. Let's see what happens during a normal spontaneous breath. We're going from the squeeze to the pull. When a patient breathes on their own, they create negative pressure inside their chest. It acts just like a vacuum. And what does a vacuum do? It pulls things in. So it yanks blood from all over the body into the vena cava and the right side of the heart. That means venous return shoots way up. So RV preload increases. And since there's no big squeeze on the lungs, RV afterload goes down. For the right heart, breathing on your own is like a day at the beach. It's easy living. But you probably see where this is going. Look what happens to the left ventricle. That same vacuum that was so great for the right side makes the left side's job way, way harder. With lower pressure outside in the chest, the LV has to generate a much higher pressure to get blood out. So spontaneous breathing increases LV afterload. And this right here is the absolute key to understanding why a patient with a weak heart might fail a weaning trial. Okay, let's just hit pause and soak this in. This table is pure gold. It lays everything out side by side. Positive pressure, it's tough on the right heart, but a breeze for the left. Negative pressure, or spontaneous breathing, super easy on the right heart, but it's brutal on the left. Seriously, if you can just burn this image into your brain, you are going to ace 90% of the questions on this topic. I promise. Okay, you've got the fundamentals down cold. Now, let's level up a bit. This is where we get into those trickier, more advanced concepts that you'll definitely see on your exams. First up, serial ventricular interdependence. It sounds complicated, but it's not. All it means is that the two sides of the heart are linked, but there's a delay. Whatever the right ventricle pumps out now has to travel all the way through the lungs before it can fill the left ventricle. This takes a few heartbeats.
So when positive pressure kills the RV's output, the LV doesn't feel that drop in filling for a few seconds. That delay is called the pulmonary transit time, and it's a classic exam tidbit.
And this brings us to probably the most important clinical takeaway of all, weaning-induced pulmonary edema. Just think about it. You take a patient with a fragile heart off the ventilator. In that instant, you are switching them from the easy on the left mode to the brutal on the left mode. Suddenly, a tidal wave of venous return hits the right heart, and a massive spike in afterload hits the left heart. If that left ventricle is already struggling, it just can't handle that double hit. It backs up and bam, flash pulmonary edema. All right, final stretch. Let's pull this all together, take it back to the bedside, and test what we've learned with a quick quiz.
So here are the 3 big scenarios you'll see all the time. Post-intubation hypotension, that's that sudden drop in RV preload. Using CPAP for pulmonary edema, you're using positive pressure to slash LV afterload. A patient failing a weaning trial, you have to be thinking, can their heart handle the massive strain of breathing on its own? Okay, you ready for a couple of questions? Let's do it.
First one, you've just intubated your patient and you see the blood pressure start to circle the drain. What is the primary, most immediate hemodynamic reason for that drop? And the answer is B, RV preload. Remember, the very first thing that positive pressure breath does is squeeze the vena cava, cutting off the blood returning to the heart. Less blood coming in means less blood going out, and that's your hypotension right there. Okay, question number 2. Think about that patient who's struggling to breathe, drowning from their heart failure. Why does putting a non-invasive mask on them with CPAP or BiPAP work so well? The answer is all about helping out that struggling left ventricle. The positive pressure in the chest decreases the LV afterload, making it so much easier for that failing pump to move blood forward and get it out of the congested lungs. It is one of the most elegant therapies we have. And that brings us to the final slide. Look, if you remember nothing else, remember this one sentence. This is your one-line, mic drop answer for any exam question on this topic. It perfectly summarizes everything. So the next time you're standing at the bedside, you won't just see a patient on a ventilator. You'll understand the incredible dance happening between the pressure in the chest and the function of the heart.